Welcome now to the discussion on Monday special, where we're talking about infertility and really solutions and options for people who are unable to have children. As I said earlier, 80 million people worldwide, 80 million couples are struggling with infertility. Let's now introduce you to my panelists. I'll start with the gentleman sitting across from me, Dr. Alfred Murage, who is a fertility consultant. Okay, and then we have Cecilia Karanja, founder of Fertility Kenya. She'll be telling us a little bit more about what they do. And then finally, we have Dr. Robinson Ocharo, who is a sociologist. Thank you all so much for joining us. Let's start with you, Dr. Murage. How common is infertility in Kenya?
Well, it's quite a fairly common thing. And normally I would say about 1 in every 6 couples will have a problem trying to conceive. But thankfully, majority of them can be helped to conceive.
Okay.
The thing that needs to be done is for them to be assessed, both the man and the woman together, and then we can always come up with a reason why and propose what's best to do.
And what causes infertility?
Plenty of things. In our setup, mostly it's sexual infections, which brings in issues with the fallopian tubes in terms of transporting an egg. And then for men, you can get blockage of the sperm transport channels and damage to the testes. And then beyond that, there'll be things like women who don't ovulate every month, or men who have poor sperm quality, who eventually may still achieve a pregnancy. So the causes varied, but depends on individual couples.
Some people might ask, what can I do to make sure that I don't become infertile? How would you answer that kind of question?
Well, plenty of things. One is to be aware initially that fertility declines with age, and we normally talk about the age of 35 in women, and men close to the age of 40. And when people are aware of that, then they'll try and conceive prior to that age, and be aware that beyond that, then chances are that they'll have problems conceiving as soon as they want. Beyond that, people need to avoid sexual infections. The best way to avoid that is either to have sex with the same person who is not having sex with somebody else, or to use condoms as protective measures, and people who get any infections, they should be treated as quickly as possible.
All right, go ahead.
And that would avoid, ongoing damage to the fallopian tubes. And
all right, I'll move to Cecilia in just a moment, but distinguish between the terms subfertility and infertility.
Well, they're sort of used interchangeably. The reason we use sub means that these people are not absolutely infertile, and all they need is an assessment to work out what we need to do.
All right. There's a lot of other questions that I'll come to you with in terms of access to these treatment options. Some people even writing in saying that they feel like they've been taken advantage of when it comes to accessing some of these treatment options. So we'll come to that just now. Cecilia, you've had your own story in terms of your journey with infertility. Take us through the highlights of that story, if you can.
Okay. I've gone through infertility. I stayed for 10 years without getting a baby. I've been married twice, divorced twice, and due to infertility. And finally, I had blocked tubes, and I was operated through a process called laparoscopy. After the 10th year, that is when I managed to get my firstborn. So I have 3 kids right now. My firstborn is 4.5, and the other one 3, and now the other one around 4 months.
Oh wow! Congratulations.
Thank you.
The time, and you said obviously the divorce came about because as a result of the infertility. Did you always know that you had the issue, or is it something that came to you later on, the realization?
During my first year of marriage, I went to the gynecologist after staying. When I got married, I thought that everything is okay. I went home and I thought I'll get a baby immediately. So I stayed for the first year, second, third year, nothing was happening. So I decided, let me go to the gynecologist. When I went, they checked on me and they found that I was okay. Everything was fine. So on the 4th year, that is when they incorporated my partner then, and they found that they had low sperm count. And after that, was told to do some medication, then he refused to do that. So during that period between the 1st and the 6th year, the 6 years that I was there, it was very violent. It was, I couldn't stand it. So basically, we divorced, and the divorce went through, and then got into a relationship whereby now when I went back to the hospital, I was found that I had blocked tubes. Yeah, and I had also fibroids. So in this scenario, I was the problem. So I was told that I needed to do laparoscopy. But that time, laparoscopy was too much for me because I didn't have any income.
Okay, so it was expensive for you.
Very expensive for me, going to around 200,000. So on the 3rd year of the same marriage, got another person, chased me from the house, took everything from the house and said that he never want to see me in that house again. Yeah. So no quarrels, no nothing. Okay. But one day go home and I found that everything was taken from my house, and he had gotten somebody else on my face. But
it looks like now, fast forward, you were finally able to get the funding to carry out the operation?
Yes, I managed to get some funding. Okay. I did some business and got some money, and then I was able to do laparoscopy. Yeah. So later on, yes, I succeeded.
Again, it's a great ending to your story that you were able to discover what happened. Dr. Ocharo, you know, I think Cecilia's pointed out something that happens to a lot of people struggling with infertility, and that's stigma, rejection. Tell us about Kenyan society dealing with infertility, your observations, and how it's handled vis-a-vis what happens abroad.
Well, in the Kenyan situation, you find that there is a transition which we have not contextualized. A transition from the grandparents guiding on infertility, do's and don'ts. That we call it the African or Kenyan soft technology. When Murage's technology came on board, that acceptance is a big deal. And therefore, there is the issue of course, acceptance of what it does and how it does. And then there is the issue of, am I going to afford it? So in that, we are caught on crossroads. So many will go, let's try it. If it doesn't succeed, I'll blame the other. Right. I'll walk away, I'll chase you away.
Do you think we can begin to change that, or is it going?
Yes, we can. We should actually.
How does someone in that situation who has been socialized to think about what you're saying, if it doesn't work, then you're the problem and I'm going to leave. How do you think that person can begin to change their mindset?
We should change. Let's start it from there. We should change. Just marrying our soft technology, which has been overtaken by events, we do no longer have the grandparent institution, and then we aggressively inform the society on this hard technology, the new technology, what should be done. First and foremost, well, trial of having babies is I call it trial, because you don't know your status, as Murage puts it, until it's not working. That's when you go for the doctor. In developing countries, India for example, we have mothers who are actually surrogate mothers, and that's their business. They know that there is the issue of infertility. This is what we are going to do. We are going to be paid to carry the baby, either biological or otherwise.
Yeah, and certainly something that I know is also here. I don't know whether we have a clip that we can run on a story we ran about surrogacy. If my director can bring that clip, and then Dr. Murage can take us through some of those surrogacy, especially the cost, because like you said, it's a business. India and further afield as well. Let's see if we can bring out a highlight of that feature that ran on Citizen TV.
Now for me, I decided when I walked into the clinic, I realized I'm comfortable. I'm helping somebody who needs the help. In return, they help me. So for me, I honestly don't think I'd be doing anything else.
About it, what is the cost of surrogacy, Dr. Murage? If someone wants to become a surrogate mother, what is she looking at earning?
Now, I think the right way to approach it is to say, number one, surrogacy is very uncommon.
In Kenya?
Everywhere, not just in Kenya, because the reason for surrogacy is, somebody who doesn't have a uterus, or they have a uterus which is damaged and has no capability of carrying a pregnancy. So it's very uncommon. And the other thing is, it should not be used as a business. It should be used as a way to help, or almost, what we call altruistic reasons. However, when somebody is a surrogate, they're going to take out their time to carry a pregnancy, you know, all the way to term and deliver. There's going to be some cost and inconvenience attached to that.
To the person carrying
the pregnancy, yes, yeah. So then the couple who wants the pregnancy carried for them should come to an agreement with the person who is going to carry the pregnancy and agree to what extent can they compensate for, you know, this individual's time and effort.
But what is the cost bracket?
I mean, there's no defined cost. It's mostly an agreement between the couples and the clinic. But it should be driven by the person who is wanting to be a surrogate, but not coming as a way to make some money.
Do you agree with that, Cecilia, that it shouldn't be taken as a business? She said, I want to help people. I don't see myself doing anything else. So there's the passion, but there's also the profit. What are your thoughts on that?
I'll go to it because we have members in our group, Fertility Kenya, who I had one member who wanted to have surrogate mother, and I tried to inquire. I got this surrogate mother who told me that before they start the process, she would have to pay like 150 every month. She carried the baby, and by the time she was to receive the baby, she was to pay 450,000.
So 150 for the 9 months, and then 400,000 upon delivery.
So basically, we're talking around 1.8 million. So it's a bit crazy when it comes to surrogacy. So what I'll say is, I wish we could have people who would come out and say that I want to volunteer to carry for these people who don't have homes. You know, yes, I would say like Dr. is saying, if they want to be given something small, it's okay. But if we could have people volunteering to just come up and say, let me just carry for that woman who doesn't have a womb, or maybe let me just give my eggs to that person who doesn't have eggs, let me donate my sperm to that person who doesn't have sperm, then it means that the cost of fertility will go down.
So more of a voluntary basis as opposed to business, and that's probably what's making it inaccessible in Kenya. Yes, that people are taking advantage of it.
Yes.
Okay.
And if I may add, you know, there is some people who want to have a surrogate for non-medical reasons. For example, you know, somebody doesn't want to carry a pregnancy, they don't want to change their physique, you know, which inevitably happens after a pregnancy. And that is what sometimes would commercialize, you know, the practice. And I think as medics, we must be very careful, you know, when accepting surrogates.
You do a proper background check on whether or not they're doing it. There's a few questions that I believe we have from on Twitter from the public that we can also ask the panel. Let's see the first one. Florence says, what are the risk factors related to IVF? Okay. So let's keep that in mind. Why is IVF so expensive? You'll notice that a lot of the questions are around IVF. Are there foods that improve sperm quality or infertility? Okay, IVF. Let's quickly talk about that before we take a short break. A lot of questions around accessibility, cost, how the method works. Could you very briefly take us through how, I mean, it was explained a little bit in the feature, but first of all, the cost implications when it comes to IVF.
Yeah, I think the standard cost in Kenya is about 400 to 500,000 Kenya shillings
per cycle. I think it's called a cycle.
Yeah, per cycle. A cycle means, you know, the couple goes through the full treatment, and after egg removal, then the eggs are fertilized, which are called embryos, then put in the uterus. That's a full cycle. And then if there's spare ones, then they would be frozen, and that, you know, takes the cost to about 500,000 Kenya shillings. Now, most of that comes with the cost of the medications that are required and the procedures that are associated with IVF. However, you're right about accessibility. We don't have many IVF units in Kenya. We have about 6 or 7 IVF units. Not all of them work on a 24/7 basis. And therefore, when there's less number of services, the demand is so high that, you know, the cost cannot be contained just basically because there's not enough services. The other thing is we don't have any government facilities offering IVF.
Is there a reason why?
Well, many reasons. Number one, fertility has traditionally been looked at as it's not a disease, which is wrong. It's defined by WHO as a disease. So I think that's one of the reasons. Number two, there are so many other competing things like infectious diseases,
right,
which now puts fertility towards the back.
Okay.
Again, it's not right.
Yeah.
If, granted, if we don't have government facilities, then we can have what we call partnerships with the private sector.
So that's an option to look into?
Yeah, that's an option to look into.
All right,
yeah.
I have to cut you short because we do have to take a short break and come back and answer quite a few other questions. Some people asking, how do smoking, recreational drugs and alcohol become detrimental to conceiving? So very practical answers as you then take us through how societies around the world approach infertility and accept it. So keep using the hashtag Monday Special K. We'll be back with the second half of this discussion. Welcome back. Remember to use the hashtag Monday Special KE. We're talking about infertility. What are the options for people out there? Very quick questions for you, Dr. Muragan. These are compiled from people who've written in. So very quickly, can clothing or one's lifestyle contribute to infertility?
Yeah, lifestyle definitely will contribute.
Okay.
Yes, yeah.
Smoking, recreational drugs and alcohol? For example, is that what you mean by lifestyle, right?
Yeah, smoking and recreational drugs, yes, they are detrimental to sperms and egg quality.
That's the smoking and drinking. What about clothing?
Yeah, clothing, it's not clear from scientific studies that it's a big thing, so I wouldn't necessarily be too worried about that.
Because some people say tight, extremely tight clothing, especially
in men, yes,
okay.
Most studies that look at that don't give a definite answer that is quite detrimental to sperms, but certainly, it's something that one can avoid.
Someone else asked me, should I take over-the-counter drugs to boost my fertility?
The answer should be no, because there is risk associated with that, and when you take over-the-counter, then you're not sure what you're treating. It could be something completely different.
How common are fertility specialists, and where are they found in Kenya?
I would say every gynecologist is trained to assess a couple who's struggling to conceive. Then beyond that, if there's need for advanced technology, then they should be referred to sub-specialists in fertility.
Someone is saying, I'm worried about people in Wajir or Rusinga Island. How do they seek treatment for infertility? And those are just examples of counties. So counties that are far out, or that many assume will not have access to this treatment, what happens to them? What happens to people who are in far-flung areas?
I would imagine every county would have at least, a few gynecologists. So that's the first point of call. And then beyond that, then do they need to be referred to an advanced center? And then I think in light of development, counties can have, partnerships with private centers where they can, send their patients.
And lastly, before we come back for the final round of questions, is there any medical cover that caters for infertility treatment locally? Cecilia is shaking her head. Because you run an organization that deals with, is it helping people cope with infertility or giving them options?
None, none, even in HIF, nothing. Nobody covers infertility. So we're just asking the government if they could just incorporate infertility in HIF. We'd really appreciate.
So right now, adoption is expensive.
Yes.
IVF is expensive.
Yes.
Surrogacy is expensive.
Yes.
So what happens to the person who has access to none of these? And I think even Dr. Ocharo can step in and...
Yeah, they actually go or resort to old, tried out methods that have worked. Get another woman, arrange for another man. These are all tried out and they work. And arrange it silently. I'm sure they will not search far if they can't access this other technology due to unavailability or affordability. They will go back to, because traditionally the child is treasured here. And the arrangements that they used to do, the ultimate things, they want to see a child. And they'll go for that.
And like I asked something earlier, and now I'll probably phrase it differently. Who does it start with for people to begin to change this narrative of infertility and the stigma associated with it in a country like Kenya? Is it the community leaders? Is it the church? And what message do they need to be spreading?
It should begin with the innovators, those who have brought in the new technology, then through the leaders, the gatekeepers, community gatekeepers, then to the community. But if the innovator is not talking actually, it should be repackaging it. in terms of the knowledge and the information, they should repackage it from the high technical language and what it does to simple language that the leaders can buy in and then sell it to the community.
And based on what he said, once it's then broken down, there used to be it needs to be supported in bringing down the costs.
Very
it's a whole cycle and ripple down effect that will eventually make it more accessible, right? Yes.
Could I add something about the cost?
Yeah.
Now she said about the investigations before treatment is so expensive than the treatment itself. The first thing to think about cost is people should have directed investigations. Not every couple requires a test for tubes or a test, for ovulation. So when they get in by a specialist who knows what they're doing, then they need directed testing, and that defrays a bit of their cost.
Yeah.
Then beyond that, some people require simple approaches like just tablets to, achieve a pregnancy. So not everybody requires to go through the whole spectrum.
Okay, so that's a misconception. It doesn't have to be the extreme all the time.
And then number 3, then we have what we call lower cost approaches even with IVF, where you can bring down the cost of doing an IVF cycle by about half what it costs today. However, there's a bit of reduction in success rates, but all these things should be tried because some couples will achieve pregnancy with them.
Very quickly, how much more common is it in men than in women, looking at the Kenyan context, infertility?
Well, we must say that looking at studies about fertility, men contribute to about a third of cases, and maybe it goes up to about 40%. So this notion that it's women should never be there, and looking backwards, what happened recently.
Yeah, and very quickly, the final question to you, he's just talked about innovators who need to then bring this information to the gatekeepers who then bring it down to the community. I guess I'll bunch you in the innovators circle. What are you doing to make this information more accessible to the public, and what are you doing to try and partner with the government to make treatment more accessible? Very quickly.
We formed a fertility society. It's called Kenya Fertility Society. So we're going to use this forum to try and front for better fertility services, and then educate people about fertility, and then possibly try and work out, can we bring the cost
Kenya
down.
Fertility Services, are you online? Do you have
Society?
Kenya Fertility Society. Are you already up and running?
We are already up and running. But not gotten into the programs that we want to initiate.
All right.
Yes.
Thank you so much for that. Cecilia, you shared a powerful story. You've even gone ahead and formed an organization to do something about it. What is your message to a couple right now struggling with infertility, man, woman as well? What would you want to say to them?
I want to tell you that you need to come out of your situation. Just come out, go get go to a gynecologist, get to know what is happening with you. Don't just sit down, because most of us just stay at home and think that we are cursed. But if you just come out, you go to a gynecologist, they'll be able to tell you what is happening with you, and they will give you a solution. And the good thing about infertility, there is a solution in every situation. If you have blocked tube, there is a solution. If you have low sperm count, there is sperm donation. So basically, you should not stay at home. Just wake up, go to the doctor, get a solution.
Okay, thank you all so much for your information and sharing your experiences as well. Stay with us. We'll be back with your feedback on Monday Special.
And where's the other part of your skirt?
You are going to die very slowly, Eloisa. Give your clothes that teddy bear softness you love with the new Gentle Care fabric softener and conditioner. The clothes so snug, it feels like a hug.
Shirika la kilimo nchini limekuandalia maonyesho ya kimataifa ya Mombasa. Kutana na wataalamu wa sekta mbalimbali watakaokupa ujuzi wa kuongeza thamani katika mavuno yako katika uwanja wa maonyesho wa Mkomani. Karibu kwa maonyesho Mombasa.
The Nicofiti Ability Beyond Disability campaign is a corporate social responsibility initiative by the Kenya Re-Insurance in partnership with the Association for the Physically Disabled of Kenya. APDK. For the past 4 years, the campaign has touched and changed the lives of over 2,200 persons living with disability by providing mobility and assistive devices in caravans that traveled all over Kenya, as well as lifts the stigma of persons living with disability. This year, the campaign aims to reach over 1,000 people all over Kenya by providing assistive devices such as mobile vending units, stylus, canes, and even diapers. Niko Fiti, ability beyond disability.
Asante Kenyari na Niko Fiti sasa. Asante sana Kenyari na Niko Fiti.
You can always spot the brightest minds. We are the future makers and shakers, delivering brilliant professionals in health sciences, medical laboratory, social sciences, and business studies with cutting-edge learning facilities. Enroll with us today in any of our branches countrywide and start your career dream.
Nurturing professional excellence.
Baker School of Medical and Health Sciences, nurturing professional excellence.
Good evening. Time to get sporty. All three Kenyans qualified for the Olympic Games 3,000 meters finals after qualifying easily in the heats early today afternoon. Two-time Olympic champion Ezekiel Kimboi was in heat 1 and qualified in third position. Bremen Kipruto qualified from heat 2, finishing second, while Conseslus Kipruto qualified from heat 3, finishing first. Patrick Kimgeno from Bomet County and Bones Jepkerui from Nandi are the winners of the Safaricom Kisii Half Marathon held in Kisii County. Jepkerui beat last year's winner Grace Momanyi to win in a time of 1 hour 11 minutes and 53 seconds. She was followed by Georgina Rono and Elizabeth Rumoko. Patrick Kimgeno took the lead in the men's category to win the event in 1 hour 7 minutes and 46.92 seconds. The winners of the E10 road race held last week, Cosmas Birech and the